Tonight we're going to talk about rheumatoid arthritis. It's a very common disease, very important condition. And since returning, I've seen quite a bit of it actually, some fairly dramatic cases. And so we're going to talk about what it is and what can be done about it. So what is rheumatoid arthritis? It's an autoimmune disease. And what does that mean? That simply means that this is a condition where the body attacks itself. The body fails to recognize a part of itself as friendly, and it basically attacks it. That component in rheumatoid arthritis is the synovium of the joint, a particular component of the joint lining, and that causes inflammation, it causes pain, and it causes the arthritis of rheumatoid arthritis. So this disease is found worldwide. The incidence, about 1% of the population will have rheumatoid arthritis, and about 0.5% of the population will develop it on an annual basis. It's a disease primarily of the middle-aged to elderly people, even though some young patients can get it. The peak age in females is about 40 to 60, with males tending to be a bit older. There's a slight female predominance, and that there's twice as many females have it than males. So what's the impact? What's the importance? Why is rheumatoid arthritis important? Because firstly, beyond it being a joint disease, it's a disease that increases the risk of coronary artery disease, of atherosclerosis, which drives not only coronary artery disease or heart disease, but strokes. It also increases the need for surgeries. It's a disease that causes disability, loss of productivity. It just ruins, it can really affect the quality of life. And it can actually shorten your life as well and increase your mortality. So what are the risk factors? The most important, the most well-established, the genetics of rheumatoid arthritis is that there is a genetic component. It can be familial. It's not 100% a genetic disease. There's an interplay, like most conditions, between the genes and the environment, evidenced by the fact that if you have identical twins, about 15 to 30% of those twins, if one twin has it, there's a 15 to 30% chance that the other twin will develop it. If you have the non-identical twins, there's about a 5% chance that the other twin will develop it. The best established gene that's associated with rheumatoid arthritis is called the HLA-DRB1 gene, and that really increases the risk of rheumatoid arthritis in individuals who have it. The best established risk factor for rheumatoid arthritis, environmental risk factor that is smoking. Smoking is a well-established risk factor for rheumatoid arthritis. When you smoke, it causes an activation of an enzyme in your lungs, which produces proteins which the body makes the antibodies to. And not only is smoking a risk factor, but when you combine, smoking will increase your risk factor about twofold. And if you have the genetic predisposition, combine that with smoking, and your risk for rheumatoid arthritis goes up to about 40-fold compared to the general population. The risk improves after you stop smoking. It takes about 10 years for your risk factor, for your risk of rheumatoid arthritis to go down to approach that of the non-smoking population. All right. So this is just a slide illustrating the enzyme, the particular enzyme that causes the body to produce antibodies. Now, in addition to the smoking, there are some infectious agents, some viruses that are associated with rheumatoid arthritis. However, there's no definitive proof, or that the mechanism isn't well established. But it is believed that certain infections, if you get them, while your body responds to them, it produces antibodies that cross-react with your joints, and that can trigger rheumatoid arthritis. We call that molecular mimicry. And there's also an association of gum disease with rheumatoid arthritis. So all of this feeds into the fact that there is an interplay between your genes, your genetic risk, and the environment. There's also a lot of excitement in the rheumatology world about the bugs in your stomach. The makeup of the bugs in your stomach can actually predispose you potentially to autoimmune diseases like rheumatoid arthritis. So that's an area of ongoing research. Rheumatoid arthritis is also, the slight female predominance in rheumatoid arthritis is thought to be related to the hormonal axis. We call this the hypothalamic pituitary adrenal axis. This is thought to be the underlying factor in why females have a greater risk of rheumatoid arthritis. Notably, rheumatoid arthritis is also associated with tragic or serious life events, which can also have a hormonal component to them. So here's a slide just illustrating the interplay of your genes. So basically, you have to have some susceptibility to have the rheumatoid arthritis. And then once you get the modification of your gene from a risk factor like smoking, the bugs in your stomach, or the bugs in your gums, this leads to alteration of the genes. The body then begins to produce antibodies against itself, which leads to the arthritis, and also the other risk factors, the other associated problems that go along with the rheumatoid arthritis, like the vascular disease, potential metabolic syndrome. Increased inflammation can produce insulin resistance, which is what drives diabetes as well. So again, rheumatoid arthritis is not just a joint disease, it's a whole body disease that can actually shorten your life. So we'll talk briefly about the immune system. The immune system is what allows us to fight off infections, what allows us to stay healthy. We have a part of our immune system called the innate immune system that is straight hardwired from birth. And then there's a component of our immune system that learns. We call this the adaptive immune system. Both of these immune components of our immune system are involved in rheumatoid arthritis. And what happens is that the cells develop the propensity to attack the joints, and then they begin to produce proteins which also further this attack. So here now is a schematic of the joint. So we'll talk about what happens in rheumatoid arthritis. So this is a normal joint. This is a schematic of a normal joint. This is the joint capsule, nice, smooth. That's the synovial lining that we hear so much about. It produces the fluid and a lot of the cells that maintain it's involved in nice, smooth joint function. You have the cartilage, which protects and lines the bones. In rheumatoid arthritis, when the immune system attacks, this is the portion of the joint that it attacks. You can see this become red and angry. It produces proteins, we call them cytokines, which then begin to attack and erode the cartilage. And you can also get bony erosions. The synovium, when it becomes inflamed, we call it the pannus. And this pannus then attacks all of the structures around it and destroying the joint, destroying the collagen, destroying the proteins, and ultimately impeding the function of the joint itself. Now, one of the most significant markers of rheumatoid arthritis is erosion of the bone. The bones actually begin to erode, and you can see this on chest x-ray. What is significant and important in rheumatoid arthritis is that these erosions occur early in disease, which we'll talk about later, which is why it's imperative to diagnose the condition early and treat it aggressively and appropriately. The bony erosions are driven by cells that eat through the lining of the bone and actually go into the marrow as well. So here we'll have another schematic of basically what happens in rheumatoid arthritis. All right, so we go from having a nice healthy joint, nice healthy cartilage, nice little bit of fluid there. Then the rheumatoid arthritis starts. The synovium that we talked about gets angry. It produces inflammation. The cartilage begins to get destroyed. As the cartilage wears away, you can see that the cartilage is being lost. Then after that, you actually get fibrous tissue developing in the joint. Now, obviously, this fibrous tissue is not going to function like this smooth tissue here. And then eventually, the bones fuse, and you get the fusion of the joint itself. So you go from having a nice normal joint to a totally fused and destroyed joint. So here's an illustration now of what you see on the x-rays. You can see this is an erosion. Looks like someone took a bite out of this bone, and the joint space is completely lost. You see there's a little bit of space there, but here there's no space. So this patient has significant rheumatoid arthritis. Now, what's the presentation? How does it present? How do you know you have rheumatoid arthritis? Rheumatoid arthritis generally has what we call an insidious onset over weeks to months. That's how most patients present. You have the joint pain, you have stiffness, you have some patients can have fevers, some patients can have fatigue, and this develops and it progresses over months. There are some patients who develop an acute onset, meaning that they get very sick very fast, but that tends to be the minority. And there are some patients who just develop joint pain in one or a few joints that go away. We call that palindromic rheumatism, and about half of these patients will go on to develop rheumatoid arthritis. So what is the difference between rheumatoid arthritis and osteoarthritis? There's regular osteoarthritis that is a wear and tear disease. In addition to the significant inflammation in rheumatoid arthritis affects a different subset of joints. So it affects the joints in the wrists. It affects the joints, we call these the metacarpophalangeal joints, and it affects the proximal interphalangeal joints. You generally won't see this type of symmetry in osteoarthritis. So rheumatoid arthritis tends to be a symmetrical disease within the joint and outside of the joint. So like we said, in addition to the pain, a significant component of rheumatoid arthritis is stiffness. Patients would report to you, or you may feel a lot of stiffness. When you get up in the morning, the stiffness tends to be worse. This stiffness you can get with regular osteoarthritis, but with rheumatoid arthritis, the stiffness tends to last for an hour or more. Patients generally take a long time to get going. If they sit down, if they stop moving, the joint becomes stiff, and it takes a long time for the joint to loosen up. And that's very characteristic. As they get going, the stiffness resolves. You can have some pain. You can also experience pain in the feet. In addition to the wrists and the hands, you can actually get pain at the ball of the foot. And there's also, you can get neck stiffness. Early in the disease, the neck stiffness has to do with ligamental inflammation. But the rheumatoid arthritis can actually cause damage of the atlantoaxial joint. You can get arthritis of the cervical spine. Now, rheumatoid arthritis tends to affect the upper neck, but not the lower back. If you have lower back pain, that tends not to be from rheumatoid arthritis. The rheumatoid arthritis, spinal involvement involves the upper spine, which is significant because if you have rheumatoid arthritis and you have uncontrolled disease, if you go for a procedure without realizing that you have neck involvement, you can actually damage your neck and damage your spine. So it's very important for patients with rheumatoid arthritis to have regular x-rays, both of their bones and also of the cervical spine as well, especially if they have symptoms. So rheumatoid arthritis, like we said, is not just a joint disease, it's a whole body disease. And you can get rheumatoid nodules, which tend to be firm and tender nodules. They occur at pressure points. You can get them at the elbows, you can get them at the fingers. You can also get involvement of the lungs, you can get involvement of the eyes. You can have what you call secondary Sjogren syndrome. A lot of patients with rheumatoid arthritis will end up with dry eyes and dry mouth. And like we said before, if you don't treat it, the joint is destroyed, and you can end up with extensive joint damage. Now, in addition to the joint damage, you can get deformities. There are certain classical deformities you can get with rheumatoid arthritis. For example, you have what's called the swan neck deformity, where it's named aptly. You have this extension here at the middle joint in the finger, and then flexion there. You can get what you call the Boutonniere's deformity, where you have this flexion of the finger. It's very characteristic. And you can also get deviation of the fingers. In addition to the swelling of these joints, you get the fingers being deviated to the outside of the hand, away from the thumb. Those are classic deformities that you see in rheumatoid arthritis. And they tend not to be reversible when they occur. However, treatment would prevent those things from happening. And that just goes to show you how destructive the disease can be. This illustration of the skin nodules that you can find in rheumatoid arthritis. They tend to be firm, generally non-tender, occurring at these pressure points. Now, the extra-articular manifestations can be seen in about half of the patients with rheumatoid arthritis. Now, here are some of the blood manifestations. Patients can be anemic. They can have low white counts. You can have enlarged lymph nodes. Rheumatoid arthritis is also associated with increased risk of lymphoma. Cancer increases the risk for cancer, not necessarily being related to the treatment, but some of the treatments can also increase risk for cancer as well. And then there are specific syndromes that you see in rheumatoid arthritis. Patients can have enlarged spleens or low white cell counts, and like a lot of autoimmune diseases, a panel of blood work can also point you in the direction of whether or not patient has rheumatoid arthritis. Now, lung disease is also common. You can have up to 30% of patients with lung disease, with rheumatoid arthritis, have lung disease. They can have interstitial disease, fibrosis of the lungs, as well as they can have involvement of the pleura. So on this side of the lung, you see that's a normal lung field. What you're seeing here is an effusion in the lining of the lung. And then here you can also have pulmonary nodules. Now, the nodules tend to be asymptomatic. They can resolve, they can remove, they can recur. Interestingly, the nodules are basically the same. They're made up of the same tissue as the nodules in the skin. They just occur in the lungs. And you can, like we said before, you can get interstitial or fibrotic lung disease. Now, lung involvement is the third leading cause of death in patients with rheumatoid arthritis, behind infection and cardiovascular disease. In addition to involvement in the lungs, you can get involvement or inflammation in the lining of the heart. That would present with chest pain when you breathe in. That's not uncommon. And as we've said before, you can also get accelerated atherosclerosis with rheumatoid arthritis. Now, patients can also present with pain in the eye, blurred vision, redness in the eye. The rheumatoid arthritis can affect multiple layers in the eye, giving you various different presentations. For example, here's episcleritis, but it tends to be localized. Redness can be painful, not necessarily associated with blurred vision. And you have more dangerous lesions. You can have scleromalacia, where there's a risk of perforation if the disease is not controlled. And here you have a patient who's had what you call scleromalacia perforans, where the inflammation destroyed the outer lining of an eye, and you have the inner layer bulge. Disease or condition will treat these side effects, these systemic manifestations, generally speaking. Now, in terms of testing for rheumatoid arthritis, there is the famous rheumatoid factor. Now, this rheumatoid factor is an antibody against an antibody. You see it in 66–70% of patients with rheumatoid arthritis. However, it's not very specific. What that means is that just because you have the rheumatoid factor, it doesn't mean you have rheumatoid arthritis. The patients who are walking around with rheumatoid factor, I've seen a number of them, they're referred for that reason, but their arthritis is just regular osteoarthritis. So the blood test alone doesn't give you the diagnosis, and it gets better. You could have the rheumatoid arthritis without the antibodies as well, so it's really a clinical diagnosis. Conditions like lupus or hepatitis can give you positive rheumatoid factors. Now, these antibodies can show up to 10 years before the disease, and most patients, however, will become positive at some point. There's another antibody, a newer antibody, that's called the anti-cyclic citrullinated peptide antibody. It's more sensitive. What does that mean? It's not as sensitive as the rheumatoid factor, but it's more specific in that if you have this antibody, generally speaking, it's more likely that you have rheumatoid arthritis. And certainly if you have both, that would pretty much clinch the diagnosis. And if not, it puts you at high risk for developing the disease. And there are patients, as I mentioned before, who will have rheumatoid arthritis without positive antibodies. And if their clinical picture fits, then you make the diagnosis on clinical grounds, because it's important to treat the patient, because as we said before, the joint damage occurs early. Some patients with rheumatoid arthritis can also present with the antibody for lupus, the ANA antibody, but it doesn't mean that they have lupus. And the testing is slightly different. When we are diagnosing rheumatoid arthritis or any inflammatory arthritis, rheumatoid arthritis can present and be difficult to distinguish from gout. So an important component of diagnosing the condition is to actually, if you can, if there's an inflamed joint, to remove some fluid and send it to the lab for analysis, looking for crystals, looking for white cells, looking for making sure the patient is unaffected. That's also a part of the diagnostic algorithm for rheumatoid arthritis if you have a swollen joint, tender joint. Now here's an illustration of the x-rays. Again, the advanced rheumatoid arthritis, as we said before, you have joint destruction. The tissues, you totally lose the space between the joints. You get the classic deformities. Now, making a diagnosis is important because diagnosing the condition and treating it early prevents the damage. So how do we make the diagnosis of rheumatoid arthritis? How do we analyze it? What criteria do we use? It's a clinical diagnosis. So there are a number of factors that you want to take into consideration. The number of joints and the size of joints, or the size of the joints, is important in terms of determining if you have, or if you have rheumatoid arthritis. Larger joints tend not to be as specific. The more joints you have and the more small joints you have, the more likely it is that you have rheumatoid arthritis. So these joints would be the joints in your hands, the joints in your fingers. Those are considered small joints. The antibodies, while not being necessary, significantly increase your risk of having rheumatoid arthritis. If you have inflammatory markers in your blood, whether they're positive or negative, that increases your risk of having rheumatoid arthritis. Now, the duration of disease, if you have symptoms for more than 6 weeks, that's considered a chronic arthritis, which again increases the risk. Now, the way you would use these numbers, basically speaking, to have a diagnosis of rheumatoid arthritis, you would need a score of 6 or more of any of these components to be clinically diagnosed with rheumatoid arthritis. Now, this score was put together by the American College of Rheumatology and the European League Against Rheumatism, two organizations that study rheumatoid arthritis in terms of and provide recommendations for treatment, guidelines for treatment, etc. Now, how do we treat rheumatoid arthritis? The treatment of rheumatoid arthritis can be thought of as two components. There is treatment of the pain, because no patient wants to be in pain, no patient wants to suffer, you don't want your patient to be in pain. But in addition to treating the pain, you want to stop the condition. And so what we use are called disease-modifying anti-rheumatoid drugs, the most common of which is methotrexate. So these are medications that you use to stop or arrest the progress of the disease. You want to employ these drugs within the first 3 to 6 months of diagnosis to give yourself the best chance of arresting the destruction of the joint. In addition, the algorithm for treatment, generally we start with methotrexate first if the patient can tolerate it, and then you add oral medications as the case may be. However, a number of patients will not be able to be controlled with simply oral medications, and there are multiple biologic medications you can use to treat the rheumatoid arthritis. And so it really becomes a matter of what the patient responds to and escalating the care over time. Generally speaking, patients are assessed at least every 3 months after they're stable to determine the effectiveness of the treatment. So how do we determine if treatment is effective? What we do, we have a number of disease activity scores that we use, that we incorporate the patient's perception of pain, the number of tender joints they have, the number of swollen joints they have, and their blood work in terms of markers of inflammation to determine whether or not the patient's disease is controlled. So in addition to early and aggressive treatment, we treat to what's called remission or low disease activity. So for example, the most common score is disease activity score, the DAS-28, where essentially we use the we use a joint count, as well as the patient's assessment of how painful they are, along with their markers of inflammation, and we actually calculate a score. So when treating patients with rheumatoid arthritis, we generally count the shoulders, the elbows, the joints in the hands, and the number of tender and swollen joints they have, in addition to their blood work, in addition to how they feel. You can calculate a literal score, and then you can use that from visit to visit to track how the patient is progressing. For example, we consider a score of less than 2.6 remission. Ideally, that's where you want to get the patient, but if not, low disease activity is acceptable, 2.6 to 3.2. There are multiple other scores, but this is the most popular score. So what is criteria for admission? How do we know that we're treating the patient well and the patient is responding to treatment? What's the objective? The reason for criteria for admission is because we want to develop what you call objective measures, or as close as we can to objective measures, to standardize the treatment and improve the outcome. So what we're looking at is morning stiffness for less than 15 minutes, no fatigue, no joint pain, no tenderness, no pain on motion, no soft tissue swelling, and then the inflammatory markers to be within the normal range. Now, patients with rheumatoid arthritis have different courses. There are some patients who have a very aggressive course, and their inflammation will just continue to progress. Their symptoms will continue to progress. There are some patients who have an acute severe disease that just gradually goes over time, and then there are patients who flare intermittently. But either way, in terms of treatment, controlling the disease early is important, because the damage, again, we said, is done early. And in addition to that, the vascular risk occurs early as well. So what are the prognostic factors for rheumatoid arthritis? How do you know? How can you look at a patient and predict or determine whether or not they're going to have a bad course, or they're at risk of having aggressive disease? The younger the age of onset, the more joints involved, their functional status at presentation, whether or not they have extra articular features, whether or not they have rheumatoid nodules, whether or not their antibodies are positive, and if they have comorbid cardiovascular disease. These are indicators that they will require they're going to have an aggressive course and need intensive treatment. Again, just want to reiterate the systemic effects of rheumatoid arthritis. It's not purely joint disease. It goes beyond that. This is a disease that will lead to premature cardiovascular events. It's a disease that can potentially shorten your life. Furthermore, patients with prolonged inflammation can develop insulin resistance, which is a risk factor for diabetes. So in terms of treatment of management of rheumatoid arthritis, we look for we want to make the diagnosis as early as possible and begin appropriate treatment to manage to control the condition and ensure the best outcome.
You've been watching Doctors Hospital Distinguished Lecture Series, presented every third Thursday in the month. Thank you for joining us.